Welcome to this session on patient ventilator Dyssynchrony. My name is Leo Heunks. I'm a pulmonologist intensivist from Nijmegen, the Netherlands. And unfortunately, Professor Antonelli was unable to attend this session. But I think we have a very interesting list of speakers. And I'm happy to introduce the first speaker, Professor Laurent Brochard from St. Mike's Hospital in Toronto. And he will discuss, quite provocative, I guess, that Dyssynchrony is good. Please, Laurent.
Thank you so much, Leo. Thanks for the invitation. And I'll try to convince you that patient ventilator asynchrony is not always bad and may even have nice side effects for the patient or for the medical team. So my conflict of interest, I'm working with companies for research grants or equipment. So I'd like to go through three different examples of asynchrony, which may at times be bad, but not necessarily, and even have nice, interesting side effects. So I will start with reverse triggering. Reverse triggering was an asynchrony described because it's an observation which was made in patients under controlled mechanical ventilation, sedated, and where we found that the diaphragm or the respiratory muscle could be triggered by the ventilator and not the opposite. That's why we called it reverse triggering. So the first accidental observation was really that we recorded signals from a patient who was sedated on pressure-controlled ventilation. And you see on the airway pressure that it's very regular. It's the set rate on the ventilator. But when we recorded the signal coming from the patient, which was the electrical activity of the diaphragm, we noticed that at every breath, in the middle of the breath, there was a contraction. So this contraction was not triggering the ventilator, but it was like the opposite, because when we change the rate on the ventilator, it also changed the rate of contraction. And people say the brain is entrained by the ventilator. So of course it can have consequences like increase in tidal volume. This is an example where reverse triggering is every other breath, and you see the tidal volume goes up when you have reverse triggering. And at time, but relatively rarely, it can even trigger a second breath. And this may be difficult to diagnose at the bedside because you need to differentiate the first breath, which is mandatory breath, and the second one, which is triggered by the patient. This is very, very frequent. I would say at least if you look at the patient even a few minutes a day during assist-controlled ventilation, you will find it half of the patients. And the factors associated with reverse triggering are low tidal volume, high respiratory rate. This is important because it means that the rate you set on the vent is higher than any potential rate of the patient. It's associated with less opioids when you compare in a whole group of patients under sedation. But interestingly, it predicts that patient will transition to spontaneous breathing. So why is it not necessarily bad? Well, because it may, with moderate efforts, be protective for the diaphragm. And in fact, we did an experimental study to show that. This was done by Felipe Damiani on an animal model. It was very easy to generate reverse triggering in the animal model. And we found that some animals had high effort associated with reverse triggering, some moderate effort, and some low effort. And compared to a group of animals which were under passive mechanical ventilation, so this is the PDI twitch which assessed the function of the diaphragm, we found that when the effort was low, the PDI twitch was even better, which means there was a protective effect of this asynchrony, which prevented from disuse atrophy of the diaphragm. So it may have beneficial effect when it's not very strong and inducing double breast stacking, if you want. And in addition, when you look at when you look at patients who have reverse triggering, we question the idea that many of them will be rapidly transitioned to spontaneous breathing. And in fact, we said, well, what happens if we stop the ventilator? So by, for instance, doing an occlusion at the end of expiration. And you see that that's what we observe in many patients. They do have their own intrinsic drive. And usually it's at a respiratory rate which is lower than the rate set on the ventilator. So you don't have to do an occlusion. You could also switch to pressure support. And in fact, when we see reverse triggering now, we say, well, maybe this patient is ready to be switched to pressure support. And that's an incentive for us. And that's something we'd like to test in a study, to go quicker to pressure support and to stop sedation. Of course, you need to check that, because you will see that in some patients, there is nothing. There is no effort, so it's not time to switch to pressure support. So interesting asynchrony, which can be beneficial for the diaphragm in some time, and which can be used as an incentive to go quicker to spontaneous ventilation. Okay, let me give you a second example of a situation where asynchrony can be bad. At the early phase of ventilation with hypoxemic respiratory failure, there is a potential harmful effect of synchronizing the patient and the ventilator. Why? Well, because these patients, even if they don't have a very high drive, the drive of the patient plus triggering the ventilator may induce very high tidal volumes and may be potentially harmful for the patients. This was a study we did first on a bench and then in a pilot study, showing that if you compare different modes of ventilation with the same pressure settings, from fully synchronized on the right to non-synchronized, and non-synchronized, as you know, is, for instance, the mode which is used for APRV. This was not APRV, but this was just pressure, usual pressure settings. You see you have more tidal volume and less variability when everything is synchronized. And we say maybe that's a good way at the early phase of hypoxemic respiratory failure to keep some spontaneous ventilation without the risk of this synchronization. So we did a randomized control trial. That was very brave to do that because it was complicated to convince people that we could go for a non-synchronized mode. And we used a mode which looked very much like standard pressure control ventilation settings, but you see that the patient was able to breathe on top of the ventilation at any time. And the ventilator can tell you how much of spontaneous ventilation is done by the patient. So we tested that versus a classical assist control ventilation with sedation, and we tried to make the two groups as similar as possible. So we randomized the study and entered more than 700 patients. And we couldn't find a difference in the main outcome, which was mortality or ventilator-free day. However, interestingly, we found that the group in the mode which was non-synchronized received less sedation, midazolam and propofol, less opioids, and less neuromuscular blockers. What we regretted at the end of the study was that the people tended to be shy and probably not to use a lot of spontaneous ventilation. But we think this situation, very specific, can benefit from this non-synchronized ventilation. So some food for thought. And let me finish by a third example, which would be double triggering during assisted modes. By assisted modes, I mean pressure support, NAVA, PAV, proportional assist ventilation. We have been told that double triggering is bad because it can increase the strain and the risk of overdistension. However, when you look at double triggering, and I show you here examples in the 3 modes. So this first one is NAVA, the second one is PAV, the third one is pressure support ventilation. And you see in each tracing examples of double triggering, which creates, if you look at the last tracing, a relatively large tidal volume by the phenomenon of breath stacking. So we say, well, first, it's not very frequent. It's relatively rare. And second, we say, is it not simply the natural variability of patients? For instance, you and me, we do size from time to time. It's a natural phenomenon. And what we found in this study was that there is a very strong correlation with patients' variability and occurrence of this breath stacking and double triggering. So it may not be something especially harmful, but just the reflection of the natural variability of the patient. And in addition, when we look in more details, we found that in many patients, in most of the patients, this was not associated with any expiratory muscle activity, and which means that they just accepted a higher tidal volume and with a longer expiration. In some patients, it was associated with positive expiratory muscle activity, which was associated also with a decrease in lung volume. So there may be some patients where it's not completely natural, but in many of the patients, it's probably a natural phenomenon on which we should not try to react. And maybe it has the same function that normal size in normal individual. So maybe you will not, you will forget many of the information I found, but the main message here is that patient ventilator asynchrony may be just simply something, a natural and safe response of the patient. The adequate response may not be sedation all the time. And my feeling is that part of the negative association we found between asynchrony and outcome may be related to excessive sedation that we tend to give. So it may indicate inadequate settings, and when you see that, you should not blame the patient, but maybe blame the settings. And again, sedation should not be the only response. Thank you very much.
Thank you very much, Laurent. Questions from the audience? Please raise your hands. Maybe I can start. You said something very interesting. You said something like the patient accepted a high tidal volume because he did not recruit the expiratory muscles. So do you mean to say that if a patient is on pressure support ventilation, tidal volumes are high, and patient is not recruiting expiratory muscles, that this is acceptable? So what did you mean by that statement?
I mean, we look, we say, okay, so maybe you don't want this big tidal volume and you have breath stacking. So the natural reaction may be to try to expire this volume more than by recruiting the expiratory muscles more than during the preceding breath. And in fact, we found that in many cases, it was not the case. So like if the patient really wanted this big tidal volume and did not want to expire more quickly. So that's an interpretation.
Okay.
And it was not just the recruitment just for this breast, it was an additional recruitment based on the expiratory increase in gastric pressure compared to baseline.
Okay.
It's just an interpretation.
Right.
Right.
Okay.
Just one question.
Can you please introduce yourself?
Yeah, I'm Dr. Sarkar from Kolkata, India. So I know it's Dyssynchrony may be good for the patient for a certain period of time, but it will be definitely, if we allow to go ahead with the Dyssynchrony in a patient for a long time, then might be deleterious. So how long we should allow them to have that Dyssynchrony?
So what I'm trying to say is that we should try to, that's a very good question, we should try to interpret what's going on. And we have a natural tendency to be happy if the curves are very regular and very smooth, but I don't think that's the natural behavior of patients. And what I was showing is that, for instance, this reverse triggering, this may be an help for the clinician to say, well, maybe my patient, it is time to change to decrease sedation more rapidly and to go to pressure support. So to your point, not to prolong this period, but to try to accelerate. The last example I gave, which are this double triggering during assisted ventilation, honestly, that was quite rare. So I'm just saying, don't jump on thinking that's bad for the patient. I completely understand your point. For instance, if you have breast stacking every other breast, I would not accept that. I'm not saying it's always good or bad. I'm saying you need to carefully interpret. And some of these indicate that there is something inadequate between the ventilator and the patient, which may be that the patient does not want the ventilator anymore, or is just at the kind of reflex to adapt to the situation. So I'm just saying we need to be careful not to overreact and over-sedate our patient simply because we see asynchrony. But I understand it's complex, and I'm not saying that we should tolerate everything for all the time.
There's another question there, or yes, please.
How to identify this reverse triggering very clearly, actually? Reverse trigger, how to identify it?
Can you repeat, sorry?
How to identify the reverse triggering?
How what?
How to identify the reverse triggering?
So reverse triggering is often missed because it's a contraction of the patient, of the respiratory muscle of the patient, following each ventilator breath. So usually it induces a deformation in the expiratory flow curve, and the curve looks weird, right? Instead of a natural expiration with an exponential, it's amputated by the effort of the patient. And sometimes it can create a second trigger, a second breath, which is very misleading because you don't know whether the patient triggered the two breaths. And so you have to be careful to look on the ventilator, whereas the first one is mandatory, the second one is triggered by the patient. So once you have understood that, it's relatively easy to recognize, but you need to look at the waveforms. That's the best way to do it now.
Yes, please. Oh, there's no question there. I think we have...
Yes.
Yes? Oh, yes, go ahead, please.
Hi, this is Martin Angula from Uruguay. Assisted and especially controlled ventilation is associated with diaphragm atrophy. So do you think like reverse triggering could somehow attenuate the atrophy of the diaphragm?
So you could even imagine, if you want to find an explanation, that it's a kind of way for the body to protect the diaphragm, which is not used. So in fact, the way we see it is that if you have deep sedation like burst suppression, you have no drive, okay? But if you have a little bit less sedation, there is something in the brain which is ready to start breathing, and the ventilator is just giving too much compared to what the brain wants. And yes, the interesting effect is that if the reverse triggering is not too strong, it is really beneficial, it seems, at least in the experimental study, in preventing disuse atrophy of the diaphragm. So I would say if you see reverse triggering and not big deformation of the waveforms and no breath stacking, you may even say, this is good, my patient has at least some diaphragmatic activity. The concern is that this diaphragmatic activity is not exactly synchronized with the breath. It tends to be in the expiratory phase. But in most of the cases, most of the inspiratory activity is still during inspiration. So yes, it may be protective for the diaphragm, absolutely.
Thanks.
Thank you very much, Laurent. I had another question, but we don't have time. But maybe people can think about it while you're having a beer or something tonight. I was wondering if there's any evolutionary benefit of reverse triggering. I mean, why did nature think about if you inflate the lungs, that it would result in the next inspiration? And I think there is an explanation, but that's nice for during your dinner tonight to think about that. I'm happy to introduce the next speaker, which is José Dianti from Buenos Aires. And he's going to explain to us that dyssynchrony may be bad. Good, sorry, good.
No, bad.
Bad.
I'm on the bad side.
Bad, sorry.
It's funny, Leo, because you told Laurent that he had like a hard time and that was controversial, and I think I had a hard time just justifying why it can be bad, so I think I was on the other side. But as I'll try to say, and we'll probably end up seeing, and I agree with Laurent, is the bottom line is, as most things in the ICU, it depends, right? So I don't know, we'll go from there. So dyssynchrony is very prevalent. It probably happens every day for most patients. I was just chatting with a friend of mine who's an ICU pediatrician, and he actually mentioned that it happens for pediatric patients. Dyssynchrony is the norm. Like, they are all dysynchronous all the time. And I figured that would be useful for me to say. And I think it's important because, again, it depends to sort of try and differentiate different forms of dyssynchrony, because different forms might have different clinical implications at different moments, I guess. So this is not a talk on dyssynchrony itself, so I won't be super thorough about how to diagnose and how to differentiate them. I'm just going to say that one way of categorizing it is using this categorization, which separates dyssynchronies in trigger dyssynchrony, which are the ones that happen at the beginning of the respiratory phase and can happen at the inspiratory phase. So it's an effort that fails to trigger the inspiration. But as Dr. Brochard mentioned, it can occur at the end or at the expiratory phase as well. This could happen with reverse triggering as well, but it depends on semantics here, how you classify this. The main issue with this is probably, or at least theoretically, physiologically, that you are contracting your muscle as it is elongating, and this might have implications in terms of muscle injury. It would represent potentially what we call an eccentric contraction or plyometric contraction, which can be particularly injurious for all muscles. That's what actually people do when they go to the gym. They try to maximize their eccentric contractions to maximize muscle growth, and in the setting of an ICU patient who's not ready to maximize muscle growth because they're inflamed and have sepsis and malnourished, this might lead to muscle dysfunction. Then we have flow dyssynchronies, which are the ones that happen to mainly insufficient flow. And here, again, it's a question of it depends, because saying insufficient flows kind of like entails a connotation that the flow is inappropriate, and we don't know if it's inappropriate because we said it inappropriately or because the patient wants an inappropriate amount of flow. The main issue with this is that this is potentially associated with dyspnea, which is probably one of the worst symptoms referred by patients. So this is something that it might not be that the dyssynchrony gives you dyspnea, but that this highlights that the patient is dyspneic, and it should be bad because we had to do something about that. And finally, we have cycle dysynchronies, which are the termination or the cycling of each breath, which might eventually result in what Dr. Brochard mentioned as breath stacking eventually if it manages to trigger another breath. And this might lead to the delivery of high tidal volumes, which might lead to high driving pressures into the lung, and this might be injurious. So dyssynchrony can be harmful for the lungs, the diaphragm, and can give you dyspnea, which is a very uncomfortable situation, and for these reasons probably can be bad. So there's a healthy amount of information regarding how dyssynchrony affects patient-centered outcomes. I think the big issue with all of this, and I'll be upfront with it, is that it's very difficult to make sure to ensure that these are causal associations and not just reflecting severity of disease. And this will be transversal to all the papers that I will just mention. Some have models that are better adjusted, so we probably could think that they better reflect reality. But again, the big elephant in the room will still be that this evidence doesn't come from randomized trials, so causality is hard sometimes to ascribe. So in the first paper by actually Dr. Brochard, this is a prospective cohort of patients, any patient receiving invasive mechanical ventilation that were already triggering the ventilator, and dyssynchrony was detected from the ventilator waveforms during a 30-minute period. So no specific software or whatsoever, just looking at the screens. And what they found is that an asynchrony index, which is basically the number of asynchronies or dysynchronies in a minute divided by the total number of breaths, including the ones that deliver a breath and the ones that are counted as ineffective efforts. So that gives you a percentage. So whenever that percentage was higher than 10%, so in the patients, I should say, who had an asynchrony index higher than 10%, had larger duration of mechanical ventilation with a very impressive 25 versus 7 days of mechanical ventilation, and of course had higher incidence of duration of mechanical ventilation longer than 7 days. No signal on mortality there, but for sure signal on duration of mechanical ventilation. So up front we can say dyssynchrony is associated with prolonged duration of mechanical ventilation. This is a somewhat similar study, but evaluating only ineffective triggering, so the first one, the one that triggered dyssynchrony, and its effect on duration of mechanical ventilation and on hospital stay. Again, a prospective cohort in all comers with receiving invasive mechanical ventilation, in which the authors found not only that the duration of mechanical ventilation and the 28-day ventilator-free survival was lower in patients with an ineffective triggering index larger than 10%, but also that this reflected on a prolonged ICU stay and prolonged hospital stay as well. So again, another patient-centered outcome, dyssynchrony could be associated with prolonged hospital stay. It could potentially be associated with mortality as well. So again, another prospective cohort in all comers, with the difference that here dyssynchrony was detected using dedicated software. So, sorry, my bad. So a bit more granular data than just looking at the waveforms for some time, although then we could argue how good it was, but different method, I would say. And in this study, dyssynchrony was associated with mortality. So 23% mortality for patients with an asynchrony index less than 10%, 67% of mortality for patients with an asynchrony index larger than 10%. So impressive numbers, frightening numbers, I don't know. Again, the main issue here is that it's very hard to disentangle what is causal association and what is, let's call it incidental association via severity of disease. This model did adjust for most known confounders, for sure, because we're not randomizing, and measured confounding can't be discarded here. So I'm going a little bit on the it depends part of the story, which I think it's probably what's going on. This is a very interesting study where they evaluated not only the presence of ineffective efforts, but also how they appeared during time. And they named this, or they defined these clusters of ineffective efforts to certain situations where on a 3-minute period, patients develop more than 30 ineffective efforts. And you can see actually on their tracings, on the VENT tracings, you can see that for the longer period of time, patients might be developing one or two ineffective efforts, and those go around throughout the day. But at some point, some patients develop these clusters where they suddenly started producing a lot of ineffective efforts. So the investigators here try to answer the question, okay, is this entity, these clusters, are they different than just having ineffective efforts? Well, it turns out that apparently it is. So if you count all patients with larger clusters, so here is the events here, as they count them, are in blue, and the non-events, so the normal ineffective triggering are in yellow. So longer ICU stay, longer duration of mechanical ventilation, and more incidence of patients past 8 days of mechanical ventilation, so receiving mechanical ventilation for 8 days. Interestingly, this was also the case in patients with ineffective triggering less than 10%. So the patients who did not have the clusters and didn't have that many ineffective triggering, well, when they did have the clusters, they did have prolonged ICU stay, and they did have a higher incidence of being on the ventilator for 8 days. And this counts there as well, and to hospital mortality. So patients with clusters of ineffective triggering had higher mortality than patients without these clusters. Kind of pointing to the idea that maybe it's not just having ineffective asynchronous, in this case ineffective triggering, but how these occur, and there could be some biological substrate as to why patients are breathing like that, and that might be the thing that's driving mortality. Finally, maybe less of a strong, I wouldn't say not less of a patient-centered, but less stronger than mortality or ICU stay is dyspnea, which I would argue most patients will consider it as important because it's probably one of the most uncomfortable feelings. So it appears that it could be that also dyssynchrony is associated with dyspnea, and this prospective cohort prospectively evaluating the presence of dyspnea and evaluating if change in ventilator settings worked to sort out the sensation. They noticed that most of the patients who had dyspnea were actually on volume control mode, so with a set flow. And when they did interventions to address this dyspnea, which was in terms of ventilator changes, they usually changed it to pressure support or liberalize the flow. They found that actually dyspnea and anxiety both significantly decreased while they made these ventilator changes, suggesting that maybe this flow asynchrony that I mentioned previously is actually very, very uncomfortable for patients, and that could be an important issue as well, other than just seeing the double triggering or the ineffective triggering. To wrap it up, and again, I think this goes to the it depends part of it. Identification of the type of dyssynchrony is probably very important, and then our decision-making will also be very important in that sense. Ineffective triggering, for instance, is associated with deep sedation. So patients who are more sedated usually have more incidence of ineffective triggering than patients who are less sedated. So it could potentially be a good idea, in this case, to actually liberalize sedation and let the patients breathe, and that might lead to less ineffective triggering. However, then we have to make decisions if it's another kind of dyssynchrony. Because in this kind of dyssynchrony that involves breath stacking, for instance, the investigators tested, let's say, 2 interventions. One was increasing sedation analgesia, and the other one was changing ventilator settings. Again, for breath stacking, changing ventilator settings, liberalizing volume control to a flow and limited mode, did significantly decrease the number of breath stacking events, so good. However, this does come at the expense of tidal volumes being higher, and this is obvious. It's because the patient is making breathing efforts, and this leads to higher tidal volumes and higher transpulmonary pressure. So at that point, the it depends part comes into play, because we actually have to make a decision whether this is appropriate or not, right? And we don't have good numbers to guide, we don't have good thresholds, but then our rationale there will be, okay, is this liberalizing of the flow and the volume okay for this patient in the sense that it's not developing high respiratory efforts and high tidal volumes, well, then that might be a reasonable thing to permit, to allow. If that's not the case, if this leads to high respiratory efforts that lead to high transpulmonary pressures, then the answer might be no. So just to wrap it up, and I have 2 minutes to spare, patient ventilator dysynchrony is very, very relevant, and it is associated with dyspnea, duration of mechanical ventilation, length of stay of mortality. One important thing is we're uncertain whether there is a causal relationship within these associations, and I'll just kind of like reinforce that because there's, I think, no really good way to analyze this without this bias, potential bias. And importantly, different types of dysynchrony respond differently to interventions, so the dysynchrony can be bad part, I think, kind of like lives in that area. Thank you.
Thank you very much, Jose. This was really great. Great overview. Are there any questions at this point? So, what I think is very important, because you try to convince us that dyssynchrony is bad. Laurent tried to convince us that dyssynchrony may be good. But I think what we're looking for is how dysynchronies, asynchronies can result in adverse outcome. I think the studies you've showed are quite convincing to show that it is associated with adverse outcome. Laurent suggested that this may be related to sedation. So do you have any additional thoughts how a poor patient-ventilator interaction could affect outcome, and is there something modifiable? Is it different if we improve patient-ventilator interaction?
Well, so I think sedation for sure plays a big role. And that's because we use sedation mostly to modulate patient effort, I guess. And I think that the combination between sedation, the magnitude of the patient effort, and the delivered transpulmonary pressure is where we should try to kind of focus and find a solution there. And through a combination of those three, one is an intervention, the other two things are things that we have to monitor. I think that's where we can actually address this issue. If the respiratory effort is not huge and it doesn't lead to excessive transpulmonary pressures, and gas exchange is maintained. I didn't talk about gas exchange. Some of these asynchronies might also impair correct gas exchange. They might impair proper minute ventilation, so that might be an issue as well in certain patients. But as well as homeostasis is preserved and we can kind of provide this lung protective ventilation during spontaneous breathing, I think the appropriate thing or potentially appropriate thing would be to actually try and reduce sedation and try to go through the pathway of assisted ventilation through possibly proportional modes or even pressure support. And if that's not the case, I think then we'll have to resort to eventually trying to reduce that respiratory drive and effort because I don't think there's kind of middle ground. That would be my take on that.
Yeah, right. But I still find it very hard to understand that a wasted effort in the end can affect mortality. But maybe before, because there's questions from the room. It's more. There's a question over there or here? Oh, right here. Yes, please, Noel.
I don't know if you agree, but I think, so as I completely agree that you need to differentiate different type of asynchrony. Ineffective efforts has been the one which has been mostly described in the initial studies. And I would say ineffective efforts is mostly a iatrogenic problem. So it may be too much sedation, but it's most of the time too much ventilation. And therefore, it's, to me, the interpretation that it's associated with mortality is not a direct effect. It's because we are prolonging the time on the ventilation by giving excessive ventilation compared to patients' needs.
I agree.
So I think it's, we may have been wrong in thinking it's directly harmful, but it's a marker that we are not delivering the right ventilation at the right time.
And do you think if we take sedation part out, that there is no association anymore, or do you still think?
No, I do think it's ventilation, too much ventilation.
Too much ventilation in the sense of?
Too much pressure support.
Too much
support.
support.
The difficulty with pressure support is that you very rapidly reach a point where you give more than the patient's needs, And that's where the problem happens, which are apneas when the patient is asleep or ineffective effort.
Right. There was actually a very nice study from Alexander de Moor, I think 10 years ago, that shows that especially in COPD patients, ineffective efforts are associated with less dyspnea, right? Because there's more time for exhalation. If you do not trigger the ventilator, you have an additional expiration and it reduces hyperinflation.
Yeah, probably COPD patients, I was going to say, the pathophysiology of why the ineffective efforts occur is kind of different because it's not so much related to sedation and maybe more related to like the threshold load on initiating a breath, right? Which doesn't have to do with sedation, but with mechanical stuff from the lung.
Okay. We have time for one short question and short answer, please.
So yes, the same question actually, to elaborate more. So we have noticed a lot of patients in our ICU have a very high tidal volumes. And what we do normally, so sometimes we increase the pressure support. Sometimes we change the respiratory rate. So what is the most reassuring strategies in terms of pressure support or respiratory rate we have to adjust in order to reduce this large tidal volume, or should we wait and observe?
Well, so what I would say is that we have some data that suggests that if you want to limit, and I will be very clear, if you want to limit tidal volume and lung distending pressure, the thing that works the best is to sedate. The thing that works the best between titrating more pressure support or increasing sedation is increasing sedation, because titrating more pressure support works because it will reduce the effort, but at the expense of maintaining the transpulmonary pressure at the same level. So if your goal is lung protection at that moment, and that's what you want to limit, sedation is the way to go, I think.
Thank you very much, Jose. We're moving to the next. Moving to the next presentation, which is from Professor Niall Ferguson from Toronto, Canada, and he will discuss the impact of post-inspiratory diaphragm loading. Please, Niall.
Thank you. Thanks very much. And apologies a little bit for my voice. I'm fighting a little bug here. We're going to switch gears slightly and talk about a little bit dyssynchrony, but really with a focus on diaphragmatic function. These are my disclosures, nothing particularly relevant for this talk. This is an old review article but I still like this schema, and I use this as my framework for thinking about the difficult to wean patient, or the patient who's hypercapnic for whatever reason, thinking about both a anatomical approach on the supply side and a load-based approach on the demand side. I point out here that many things can contribute to diaphragm dysfunction, and diaphragm dysfunction from multiple causes is an important cause of weaning failure and prolonged mechanical ventilation. Let's look at the diaphragm. Many of us are just looking at the diaphragm when we see it on a chest x-ray, where we see the dome of the diaphragm, and we don't see is the zone of apposition. And this is where all the action is really happening in the diaphragm, where it's acting like a piston and lowering the diaphragm and creating negative pressure within the chest. As I said before, there's lots of different inputs that may be driving diaphragm dysfunction in our ICU patients. I'm going to put it to you that one of them may be mechanical ventilation and how we're using the ventilator. And this has important impacts. Much more strongly associated with difficulty weaning is evidence of diaphragm dysfunction, much more so than even ICU-acquired weakness, although there is some impact there. You can see here when diaphragm dysfunction was present, we had 80 or 90% probability of weaning difficulties. So how do we measure the function of the diaphragm? When you're looking after your patient, how do you know what's going on there? There's a laundry list of possible techniques that you might use to look at the diaphragm. But the gold standard, if you ask a physiologist, would be to put in an esophageal and gastric balloon so you could measure transdiaphragmatic pressure in response to maximal magnetic twitch stimulation of the phrenic nerve, as seen here. This is possible to do in the physiology lab. It's challenging to do, I would say, in our day-to-day ICU workflow. And there's technical concerns about, in a non-awake patient, had to be sure that you have supramaximal stimulation and that you're not seeing changes that are a result of differences in thoracic volume. There is one study that's actually done this, so I'm very impressed that Alex Demoule's group in Paris used twitch stimulation and categorized patients into having or not having diaphragm dysfunction. A lot of patients with diaphragm dysfunction strongly associated with bad outcomes in this small study. But another way to measure diaphragm function, I'll say, is to use ultrasound. And not necessarily how we traditionally used ultrasound to look and see the diaphragm moving up and down, but to use M mode and see the diaphragm thickening with each contraction. Just as when you contract your bicep and it thickens, so too when you contract your diaphragm, we see thickening there with each breath. And you can quantify that. You can see, and using ultrasound in this way, you can get an idea of how much muscle bulk there is, so the thickness of the diaphragm and how that changes over time as you watch day to day. And you can look at diaphragm activity, measuring the thickening fraction of the diaphragm as to how much effort the patient's making. So a few years ago, Ewan Gallagher and Laurent and I wrote this piece in The Lancet outlining at least 3 different possible mechanisms by which the clinical challenges in mechanical ventilation, how the diaphragm may be impacted. We may see resting or quiescence of the diaphragm leading to disuse atrophy and weakness. We might see excessive muscle loading, or we might see what I'm going to talk more about today later in this talk, dyssynchrony leading to eccentric contractions of the diaphragm, which, as Jose was saying, are the kinds of reverse things you do at the gym to increase muscle strain. We have lots of basic animal and muscle physiology to show that actually can cause muscle injury. For a couple minutes, I'm just going to go through some of the ultrasound findings about what happens with mechanical ventilation and the diaphragm. And in this simple study where we just looked at the diaphragm thickness every day with ultrasound and recorded how active it was, you could see in patients who had no activity of the diaphragm, there was a rapid reduction in thickness over the first week of mechanical ventilation. In patients whose activity of the diaphragm was relatively normal in this 25 to 40% range, diaphragm thickness was preserved. And then there was a smaller group of patients who were doing supramaximal amounts of effort, whose diaphragms actually thickened, which was an intriguing finding to us that we weren't expecting. So we extended this study and started looking at more patients and correlating these findings with outcome. And the main findings here is that depending on what's happening to your diaphragm relative to its baseline measure when you first were ventilated, having a loss or gain of thickness on any given day decreased your probability of being successfully liberated from mechanical ventilation. That's the same data, just another way around. But we saw this consistent U-shaped curve where duration of ventilation was associated with diaphragm atrophy, where complications of mechanical ventilation also related to diaphragm thickness. And the duration of ventilation was actually related to diaphragm activity and thickening fraction of the diaphragm. So all of these things suggesting that the way that which are using the ventilator and the way that how much effort the patient is making is going to have an impact both on ultrasonographic findings, who cares, but more importantly, on real complications and patient-centered outcomes that we all do care about as intensivists. Now, for the second part of the talk, I want to talk about another way that we can measure diaphragm function and activity, and that's thanks to an innovation by Christer Sinderby, described here in Nature Medicine in 1999, where he had the idea, if we really wanted to know what's happening with the respiratory, if we wanted to drive the ventilator the way our brain drives our breathing, we would use the matrix style plug and directly into the medulla. That's a little invasive. So he had a better idea where we said, okay, we want to measure if we measure the electrical activity of the diaphragm, we can use that we can use it as a diagnostic tool to look at synchrony, and potentially in this application use it to drive the ventilator in a neurally adjusted mode. So this is a special nasogastric tube with an array of electrodes on it so that as the diaphragm moves up and down, the electrical activity is still captured within that electrical array, and the signals, electrical signals from the ECG, for example, are filtered out. Now, that then gives us a way to look at muscle function by relating the amount of electricity that the diaphragm that is created within the diaphragm and how much transdiaphragmatic pressure that creates. That's so-called neuromuscular coupling. So we measure the electrical activity of the diaphragm, and we measure the transdiaphragmatic pressure, and we calculate neuromechanical coupling by PDI over EDI. How much tidal volume results depends then on the patient's respiratory mechanics. And here you see two different patients, one fairly normal, one patient with COPD, where you see a much less efficient diaphragm in the lower panel here with large electrical activity swings leading to not very great mechanics. In a very nice study, Giacomo Bellani and colleagues studied electromechanical coupling. They called it the pressure electrical index or something like this, the PEI, so just to let you know, that's what we're talking about neuromechanical coupling here. And as you might expect, for different patients have different curves of neuromechanical coupling. But in any individual patient, as you adjust ventilator support up or down, their neuromechanical coupling curve follows a straight line, so a linear relationship. They measured this using occluded breaths to measure neuromechanical coupling, but they also measured it during spontaneous breathing and found that they're very closely correlated, but they're off by about 1.5. So you need to make a correction factor to go from occlusion neuromechanical coupling to breath unoccluded neuromechanical coupling. And when they did this, they were able to show measurements of looking at PMUS, looking at how much muscle power and generation, how much effort the patient was actually making, calculated using the traditional method of the transdiaphragmatic balloons versus the neuromechanical coupling method, showed pretty good agreement on their bland Altman plot here. So we took this idea and studied this in a series of patients who we thought were going to be on the ventilator for a week. We were trying to find patients who were going to have a longitudinal experience of mechanical ventilation, and took patients. Some of them had brain injuries, most of them had pneumonia and ARDS, and we put in a special neurovent catheter that has both those electrodes I was telling you about, as well as esophageal and gastric balloons to allow us to calculate all these things. And hourly, we would measure and record 5 minutes worth of electrical activity, airway pressures, esophageal pressures, and gastric pressures to get all these measures. And once a day, we would do respiratory occlusion and have a daily measure of neuromechanical coupling, just as defined here again by the transdiaphragmatic pressure divided by the electrical activity of the diaphragm. And then we were able to calculate PMUS using this same equation. So the first thing to recognize in these patients, here we have diaphragmatic electrical activity, here we have muscle pressure, that early in the course of mechanical ventilation, a lot of patients are doing nothing. But as you extend out, now you end up getting some patients with quite a lot of electrical activity, and some patients with quite a high drive, a gradual diminution of the patients not breathing at all. The other thing that we found in this study is that dyssynchrony was, as Jose told us, dyssynchrony is common. If you look at the proportion of patients with one or more types, it's up to 50% on average by the time you get out to to day 4 or 5. And we also found a lot of what we're calling post-inspiratory loading. Here, and we used a quite specific definition and a more sensitive definition in blue here. What is post-inspiratory loading? It means that the ventilator is breathing out, but the patient is still contracting their diaphragm. And this can happen on an example because of reverse triggering, as Laurent was telling us earlier, or simply just because of some cycle-off dyssynchrony, and it's maybe easier to see on this figure on the right. The ventilator is into expiration here. The patient is still activating their diaphragm here, and all this gray shaded area is post-inspiratory loading. So it's okay, who cares? These are nerdy curves that nobody's going to see regularly. Here's the very interesting thing. When we looked, we thought that we were going to see a strong association between excess effort, inspiratory loading, and diaphragm dysfunction because of what we'd seen in some of our diaphragm ultrasound studies. But in fact, that wasn't such a clear relationship. Here you can see both the duration and the magnitude of inspiratory loading, how much effort there was. It was not a very strong signal. Certainly no signal for harm here. Whereas there is a strong and consistent and sort of dose-response signal both on duration and magnitude of post-inspiratory loading with diaphragm dysfunction as measured by worsening neuromechanical coupling over the course of this study. And one final slide to you might say, am I just making this stuff up about neuromechanical coupling? Even in these patients, there was an association between diaphragm function as measured by neuromechanical coupling with the change in thickness from baseline. And looking at the last day of mechanical ventilation, the last day of study here, there's definitely a relationship between neuromechanical coupling and diaphragm thickening fraction and the rapid shallow breathing index during a spontaneous breathing trial. So I've tried to show you that there is growing evidence of the role of ventilation in iatrogenic diaphragm dysfunction, that we have some new data linking ventilator settings to diaphragm activity and diaphragm atrophy, and that to prevent, for muscle protective ventilation, we probably want to both prevent disuse, maybe prevent excessive loading, and thinking about preventing eccentric contractions. And with that, I will stop and thank you for your attention.
Thank you very much, Niall. That was very interesting, very new data to present. Questions? So maybe I can start. The post-inspiratory diaphragm activity, I think there's also quite some data in healthy subjects that the diaphragm is active in the expiratory phase. So obviously it's not necessarily damaging to the diaphragm. I think people working in a pediatric or neonatal ICU using NAVA will see that there's continuous activity of the diaphragm during expiration. And I think there's a physiological explanation for that. It's to recruit the lung to break expiration. Do you really understand why there is this relation between the post-inspiratory activation of the diaphragm you found and the adverse outcome? Or is this just a bystander?
Well, it's impossible to know for sure in this type of study design. It's an observation or an association that we found. But I think it's intriguing, and it begs the question that is cycle-off synchrony an important phenomenon that leads to differences in muscle function and potentially duration of outcome? And I think that's something that we could actually test in a clinical trial using modes that are excellent at cycle-off synchrony, like NAVA or PAF.
But the question remains if it's really a dyssynchrony, right? Or it's just physiology. It's there, and it should be. On the other hand, I think it's more or less hard to understand that a muscle is active, like the diaphragm, and immediately stops. It takes time to wane off the activity, isn't it?
Absolutely, and we didn't, we classified sort of diaphragmatic expiration as saying that not at, some people would say inspiration's over, the neural inspiration's over after you've passed the peak, we were a little bit conservative and said we'll wait to 70% of peak to call expiration. But there aren't exact definitions about all of these formats.
Was there a question over there, or? No, okay. So maybe I can ask a very short question.
Okay.
So
Sure.
did you see any effect of PEEP on post-inspiratory diaphragm activity?
We haven't looked at that.
Okay.
I'll have to look. Thank you.
Okay, thank you very much. And I'm happy to introduce our last speaker, Massimiliano Greco from Milan, Italy, and he will discuss about AI-assisted waveform analysis.
Hello, thank you, Mr. Chairman, for the introduction. And let me just do a little introduction about data and waveforms, how we can look at the waveforms as data, simply. So there are a lot of data we have in intensive care unit, mainly coming from the monitor with arterial blood pressure, EKG, and so on. But also we have ventilator, for example, generating a lot of data, a lot of waveforms that we have we know very well, we look at every day. And this can be seen as data. These are high-resolution data. And what are high-resolution data? If you think about nurses charting, it's about entering the data in the electronic health record is about 1 every hour, 1 every 2 hours. There are high-resolution data going to be collected every 1 minute. But when we talk about airway pressures and also EKG, we are thinking about milliseconds. So it's about 2 milliseconds for EKG, 8 milliseconds for waveform, and this is just one of the ways in which we can store this high-resolution information. So it's about 500 Hertz or even 150 Hertz or something like that. So it's a very high resolution and a very high quantity of data. And to get this very nice image, in this case is arterial blood pressure, but it's the same for ventilatory pressure. To get this data, we start from something like this. We have a series of time points, one after another, each 8 milliseconds after 8 milliseconds, so it's time going down, and we end up storing them simply as hexadecimal values, so something very short, 4 digits, to get the same as the bytes on the side. It seems very complex, but it's just to say that we are just looking at data in another form. This can be just a table, so the same waveform is just this represented in long format. So this is more or less where we are going. Of course, we can, before using this data, we have to filter them, we have to calibrate the signal, we have to normalize the signal and so on, and we can get this type of alteration. We pass, we use filters, high band, low pass filters, and we get finally the signals. Why am I telling you all this? Because we have just seen in the previous presentation that it's quite difficult to get a framework for counting and for collecting patient ventilation asynchronies. We have to go to the ventilator and look at them, but we can't be all day in front of the ventilator because we have many patients. Or we have gold standards, like, for example, electrical diaphragmatic activity. We have pressure for the esophageal pressure to get new gold standard data about this, but they are generally under-recognized and under-reported. And we really don't know if they are bad or not bad for our patient, as we have just seen. So in the past, this is an article from 2010, more or less, we have some that started using automatic algorithm to get directly from the ventilator whether there is a PVI. In this case, they looked at in 2018, they look at an effective triggering, and what did they get is that they are not yet using a machine learning algorithm. This is just a normal algorithm. So using some simple measures, if I get more than a delta pressure or more than a delta flow, then I can say that there is a ventilation asynchrony. And they get very high specificity and sensitivity, but only for this category, ineffective triggering. Then in another example here, what they try to do is the same, focalizing on cycling of the ventilator, delayed or early cycling of the ventilation. They used, in this case, a random forest, which is an ensemble of decision trees in which every trees express whether there is a probability of being a delayed cycling or a normal cycling, or an early cycling, and then the population of trees at the end tells you whether it is or it isn't an alteration, and which kind of alteration is that. Again, they got a quite high sensitivity and specificity, about 90% for sensitivity, and also for the premature termination, more or less the same. What is the problem of this article? They are based on data that we extract specifically for studies. There is no real way to monitor that directly in real practice. We need to extract data, give them to the engineers or to the one analyzing, and then going back toward this. Here we have another example, which is again a validation of an automated system for detecting ineffective triggering. In this case, it's like the first study, it's ineffective triggering. They use a ground truth, so they use esophageal pressure or electrical activity to measure when there is a real alteration and to set the ground truth. And then they have to compare clinicians detecting the alteration using only waveform from pressure and flow and not from the ground truth. So they are not using, in this case, esophageal pressure and electric activity, but this is the ground truth, so the truth that we set for the algorithm. But then they are only using waveform from flow and pressure. And the same for the algorithm, and I compare the two, and they see that at the end, what they get is that clinician has a lower sensitivity, more or less half sensitivity, and they have higher or more or less similar specificity. Again, this is related with only one type of asynchrony in effective triggering. But this is something that is very interesting, because you can imagine that we can go toward a future in which the data that we have in our monitor, in our ventilator, can be used to have a full-time monitoring, 24 hours, 7 days monitoring system. And so this is where we try to do the same in our ICU. The reason was that I was interested in data science and looking at that, and we had a retrospective collection of waveforms from ventilator. Normally we have Drager and McKay ventilator, both of them getting together without difference in these large data sets, and we try to do retrospectively to develop an algorithm able to recognize automatically the different type of PVAs. So what we did was to recruit 20 ICU patients and then to go back and take data on the flow, pressure, and volume courses. So we take the 3 courses, and we try to use several types of asynchronies. Actually, we were interested to see whether the algorithm was able to differentiate even quite similar type of PVAs. So we actually used a lot of them, even more than normally we would, but it was to see the sensitivity and the specificity of this technique. So we tried to do the labeling. We did the labeling only on manually using doctors looking at the curves, the 3 curves together, and then label the image. And then we didn't have a ground truth, so we didn't have esophageal pressure or electrical diaphragmatic activity. We just tried to replicate what the doctor do when he looks at the monitor, when he looks at the ventilator, and try to see whether there is an asynchrony. And we tried to do that. We had two parallel ways to analyze our data. One was a supervised learning with, in which what we actually did on your left is to extract some of the parameters like mean, standard deviation, minimum value, maximum value of each course, some standard analysis, and then include them into supervised algorithm. One is a random forest as before, and the other is another algorithm, which is XGBoost, gradient boosting on that. And on the other side, we use the deep learning, so neural network, which is what you normally get when using image recognition and pattern recognition, for example, in radiology. So try to see whether the algorithm is able to recognize the waveform as we do as doctors without extracting any features. So the algorithm is doing that by himself. So on the left, again, we have the supervised random forest and the gradient boosting with the feature extraction and analysis. And on the right, we developed 2 different neural networks. One on the low side, one was taking the 3 different curves pressure, flow, and volume differently, and then summarizing at the end the results of the different layer of the network. So it means the probability that it's asynchrony and which type of asynchrony is decided at the end of this neural network. And on the upper level on the right here, you get one branch neural network in which you get all together, like we look at the three curves at the same time, the same does the algorithm, trying to get flow, pressure, and volume at the same time. So these are the results of this. This is a pilot study, so low number of patients, but these are the results, high specificity, and the highest and the best results are actually for the one branch neural network, which is getting all the three together. So you can see that actually they are overlapping on somewhat. The two neural networks are better, the blue one and the red one, while XGBoost and Random Forest perform worsely, but it is something that we can expect because we are losing data when simply extracting features, 5 or 6 features is losing a lot of information, so this is why probably the algorithm is not so well. These are the limitation of the study. This is a pilot study. We don't have so much patients and so much alteration. We don't have a ground truth, so we didn't use again esophageal ballooning. We didn't use NAVA or something to measure electrical activity. So we don't have that. We are just trying to replicate what the doctors do when looking at the curves on the ventilator. We will need in the future to gather more data, and also due to privacy regulation, GDPR, and so on, we didn't include in this pilot study the clinical consequences of this of the number of the alteration, and we are not yet there with real-time detection. So this is one of the things that we will do next, real-time detection. So instead of having different chunks of data for each different breath, we will try to do the real-time detection of this breath using the same data sets. And then ideally, we want to link that at the, for example, difficulties in weaning from mechanical ventilation, failed extubation, and other outcomes. That's the future. But for now, what we actually, we weren't able to do that also for GDPR regulation and problems, because this is a joint study with Polytechnic of Milan, and in Italy we have problems in transferring data that are not completely anonymized, and so only waveform data are completely anonymized. And this is to compare these data, our data, with previous literature. We said before some of the studies used at the beginning logistic regression, something used random forest, we have seen the study from Golani before, and others already used LSTM and CNN, like convoluted neural network again, and we are the right one, the dark blue on the right of this screen, and this is an F score, and we are comparing against each of these studies, and more or less we have a similar performance than the other studies. But one of the advantages of these studies at the end is that we were able to use something that is already in place for our ICU. We are not collecting more data when we need. We have already the flow of data going to the central monitoring system is stored in a separate server, and then we can use that for analysis. So this is nothing more than standard clinical practice when we can, in this case, leverage our data and use that for detection of PVA in this case. So I finished with my study. Just a couple of final concepts. Why is all this interesting for me, and why it is all this, I think, very useful to study in the future, because we are going toward a path to more precision in the ICU. And why we are doing that? Because we are gathering more and more high-frequency data. So you can see in this article that on the right side, you have data collected at large intervals, but you can have data collected at very high resolution. And you can see that while the data more or less look at the same on the top, there are very different patterns that you only get when you have a very high resolution of data just below here. So if you don't have this high resolution, you don't get what's actually happening to the patient. You only get from the electronic health record something different. So we are going there, and so in the future maybe we will have precision medicine in ICU and maybe leveraging omics data. For example, you know omics data are genomics, metabolomics, and proteomics, and this will help us identifying trajectories. But also something more is added in the ICU, or will be added in ICU, I hope, in the next years, which is physiolomics, which is all the high resolution data coming to be used for better analysis and better trajectory prediction and so on. So in conclusion, we can see that we can use convoluted neural networks to accurately classify PVAs, at least in this pilot study experimental setting, and this is supported by previous literature, and maybe in the future we will have more and more precision medicine through the use of physiolomics. And this is just to thank the team, that is not only me behind that, 3 engineers and one resident. Thank you.
Thank you very much. This was really interesting, innovative. I enjoyed the talk. Is there a question from the audience? Yes, please. Wait for the microphone if you... Just one moment. Yeah, she's running towards you.